Thank you, Dr. Jihad. So our next speaker is Dr. Anthony Traboulsee. He is a professor and a research chair at the MS Society of Canada at the University of British Columbia in Vancouver. He is a co-director of the MS NMO Clinical Trial Research Group at the UBC Hospital and director of the UBC MS MRI Group. His research is focused on the clinical trial design, development of practice guideline for the use of the MS and MRI in the management of MS, establishing advanced MRI imaging outcome in the multiple sclerosis and the treatment of a neuromyelitis optica. His talk will be an update in NMOSD. Welcome, Dr. Anthony.
Thank you for the very kind introduction. It's an honor to be part of this conference. I'm Tony Traboulsee, a neurologist in Vancouver, British Columbia, Canada, and I've been working with NMO for most of my career, and there's been some very exciting updates to share with you that have happened over the past several years. What I'd like to cover today is really a bit of a personal experience with NMO and some lessons learned about making the diagnosis and managing patients. And it's really based part of discussing with colleagues from around the world, as well as a variety of different patient challenges I've had. I've treated close to 200 patients with NMO, ranging from children to elderly. It's quite a broad disease that way, and the needs can vary depending on the type of patient you're treating. And so over the time, we've evolved into a treatment paradigm that's been updated recently with the latest clinical trial results. I'll touch on those as well. These are some of my disclosures related to industry in the past 3 years. Any discussion around therapies will give equal value to each of the different therapies. So without going into extensive detail of the diagnostic criteria, I think suffice it to say there's been some very important evolutions in how we identify patients who might have NMO. It's quite a rare disease and often hidden in the world of multiple sclerosis because we see many more MS patients. When Devik and Galt described NMO for the first time about 150 years ago, it was really restricted to severe optic neuritis, severe transverse myelitis, all happening or occurring within a month of each other or simultaneously. And it became a very restricted clinical diagnosis. And so many of the milder or asymmetric cases where there was a delay between the two attacks were often relabeled as MS rather than NMO. And what changed our world was around 2004 was the availability and the development of autoantibodies that were very specific to NMO. And those were the autoantibodies to aquaporin 4, water channel within astrocytes, which is the pathological target for NMO. And that leads to these very destructive inflammatory syndromes that cause secondary demyelination and dysfunction of optic nerves, spinal cord, and other tissues. And so that led to broadening the clinical phenotype to include not only optic neuritis and transverse myelitis, but some less typical syndromes where lesions extend or start in the medulla around the area postrema. Patients can present with intractable hiccups and vomiting, lesions occurring in the hypothalamus or thalamus causing narcolepsy or diencephalic type syndrome. And sometimes we can see these large tumefactive lesions that would look like ATOM almost. So it became a much broader clinical experience because we had availability of autoantibodies. And that led to the enhancement and broadening of the diagnostic criteria in 2015 that allowed for a single attack in one area, such as optic neuritis or transverse myelitis, and the presence of autoantibodies to aquaporin 4 to be sufficient to make the diagnosis. Some patients, about 30% of patients, will meet diagnostic criteria that are antibody negative, and we must be more strict in terms of clinical criteria to ensure we're not overdiagnosing NMO in patients that are suspicious but may not have enough clinical criteria to meet that. So That's probably one of our ongoing challenges is the antibody negative patients, and we're discovering newer antibodies such as MOG that account for about 30% of those antibody negative patients, and we'll probably discover even more antibodies. I'll come back to antibody testing a little bit later. So I just want to illustrate this with a few typical cases. This is a very young woman, one of my early NMO patients. Initially, she was having severe recurrent optic neuritis, and her working diagnosis was multiple sclerosis. Less common to see multiple sclerosis in Asian patients, but it can occur. However, the severity was a red flag, and eventually she developed transverse myelitis. And this was just around the time antibody testing was becoming available, and her diagnosis shifted from multiple sclerosis to NMOSD. And here you can see the typical spinal cord MRI on the right for NMO, this very extensive lesion from the medulla all the way down the cord, and the cord looks swollen. What's helpful to realize is that imaging feature is usually only present at the time of an acute attack of transverse myelitis. And in follow-up, most of those lesions will break up into smaller lesions or even completely disappear. It's very unusual for multiple sclerosis lesion to completely disappear. So disappearing lesions is a potential indicator of a different type of disease, such as NMO or MOG. Now, here's a young girl who presented with the more less common brainstem syndrome. She was young. She developed hiccups and vomiting, but also then developed severe vision loss as well. And fortunately, we had access to the antibody testing. It was clearly positive and met diagnostic criteria, the new diagnostic criteria. She would not have met the older diagnostic criteria. So just in clinical summary, we can see this disease in a much broader age range than we see in multiple sclerosis. People developing symptoms, severe optic neuritis or transverse myelitis over the age of 50, one should consider NMO in the differential diagnosis. Very predominantly women more affected than men, even more so than we see in multiple sclerosis. It's around 90% women with NMO, but men can also have it as well. And each attack really carries a high risk of disability. We don't tend to see progression like we do in MS between attacks, but if patients are not treated rapidly for their attacks, they will accumulate disability that could lead to permanent blindness, paralysis, and which would, of course, lead to death due to opportunistic infections. So it is, because it is a rare disease, and most neurologists may only see one or two in their practice, just to let you know, there's been a lot of different terms used for NMO in the past, which we're hoping to see less of. MRI negative MS, aggressive MS, Asian MS, and optical spinal MS, I don't think is used much more. Lupus myelitis, I still see once in a while. And the reason for that is about 30% of NMO patients will have comorbidity with another autoimmune disease. So it's not unusual to see a positive ANA or positive ENA in the blood work. And so that should, if you see that long cord myelitis, think NMO before lupus as the cause. I put down psychosomatic as well, and that's just a reflection where I've seen some young patients where they get intractable vomiting and hiccups, and made perhaps not much detected on the neurologic examination, and so they might have been misdiagnosed as anorexia nervosa, and that could lead to a terrible delay in initiating treatment, which sadly I've seen as well. So, fortunately, we do have access to a highly specific blood test, the antibodies to aquaporin 4, and that's really helps us with these challenging cases. And so if there's any atypical or unusual features in the patient that looks like they have multiple sclerosis, but it just doesn't feel quite right, severity of attacks, poor recovery, it might still be multiple sclerosis, but should have a low threshold for doing the antibody testing if it's available. So I wanted to present another case to just illustrate that even today, we're still seeing some misdiagnosis or delayed diagnosis. And I think in part that reflects that pressure to make an early diagnosis of MS. So here's a young woman. She initially presented with intractable hiccups and vomiting, so an area postrema type syndrome, treated with steroids with good recovery. There was a lesion on her brain MRI. And then shortly thereafter had optic neuritis, diagnosed as multiple sclerosis, and put on an interferon. And she stayed on that for 7 years and would have recurrent mild attacks of transverse myelitis and was starting to accumulate some disability. And she came to my practice, but after 7 years of having this illness, and I got a new baseline MRI, and it was normal. And it would be so unusual after 7 years of multiple sclerosis, especially on one of the weaker medications, such as the interferon, to see a completely normal brain MRI. Her spinal cord MRI was rather simple, just a small lesion, and we're not seeing that long cord lesion because she's not in the midst of transverse myelitis. And so this was a concern for me that she might have an alternate diagnosis, especially with the disappearing brain lesions, the area postrema-like syndrome. And so no surprise, I tested her for aquaporin 4, and fortunately for me, it was positive. And we, of course, had to bring her back in to go over the history again and to go over the diagnosis. And she discontinued her interferon, and she immediately felt better. She wasn't having the flu-like symptoms anymore, and put her on, in this case, Satralizumab. I was able to get access to her, just became available in Canada, and she's done fantastic. Her fatigue has gone away, which I think a big part of that was caused by the interferon, and her bladder symptoms improved. And she's, I've seen her now about 2 years after this re-diagnosis, and she's doing very well with no further attacks and essentially feeling normal. So it doesn't hurt to rethink a diagnosis if a patient is looking, who's been diagnosed with MS is really not behaving as one would expect. So just a brief comment about the antibody testing. It's excellent for the aquaporin 4, especially using the cell-based assays. Very rare to get a false positive with the cell-based assay, and the sensitivity is quite high, at least 70 to 80%. The ELISAs, some people have used those for screening. They can have a false positive and also false negative rate that's higher. So one has to be careful if one's relying more on ELISAs. On the other hand, we're not quite as reliable with MOG testing. So MOG's really emerging, especially in childhood and kids that present with ADEM, but also across the age spectrum, we can see MOG, which can look a lot like NMO, both perhaps with more brain involvement. But I'm finding that the sensitivity is, I'm not sure what it is, but it's much lower than we see with NMO, and the specificity, though, is quite good with the cell-based assays. So I don't think we've yet got the best tests for MOG disease, and that's probably a discussion for a future meeting. So just shifting more towards treatment of NMO, and I think one of the really important aspects of treating NMO is treating those attacks as rapidly as possible. And that's a little bit different than how we might treat multiple sclerosis relapses, where we might ask the patient to call us in a few days or a week later to see if they're still having persistent symptoms, and then consider steroids. With NMO, we have more of a tendency to want to treat it much more rapidly just at the beginning of that attack, to try to stop it as quickly as possible. And that really relates to the higher rate of poor recovery from attacks that we see in NMO than we see in multiple sclerosis. So our standard treatment would be for very mild symptoms. My patients might take oral prednisone at home for about a week to see if that stops the inflammation. But typically, they've given intravenous steroids or intravenous steroids and plasmapheresis, and that can be effective, especially in more severe attacks, and up to about 65% of patients will respond. After that, there's no clear international guidelines of what to do. So, talking to colleagues around the world, it does vary. Locally, I use a type of chemotherapy induction with cyclophosphamide or mitoxantrone, or even rituximab when patients are not responding to PLEX. And I define a PLEX failure if they have no meaningful improvement after the 5th treatment. So it's a series of 5 treatments we typically give. The other thing I tend to give my patients is a card with my phone number. So if they go to an emergency department, the doctor there can call me directly for guidance on management. Just because it's such a rare disease, I really don't expect emergency doctors to really know how to manage it the way we like with the acute treatment with steroids. So there are some really important differences in the management of NMO compared to MS. And again, relapses, I can't emphasize enough the importance of early rapid treatment. When there's, even if it's suspicious, you're not 100% sure, as long as they're not having an infection, there's little harm we can do by treating it with some steroids. Though one could argue that, of course. But prevention is really important, being on preventative treatment. And it's not uncommon to have to use combination treatment for patients. Certainly where a lot of patients will fail is in that misdiagnosis of having multiple sclerosis, and the older generation MS drugs like interferons, glutaminyl acetate, and even some of the oral medications are so ineffective or might even do harm in NMO patients, whereas they can be effective for MS patients. Again, comorbidity is quite common, and that might impact on what treatment you use. There are some variety of guidelines or recommendations, expert opinions from around the world. Just listed here are some of the ones. These were made before there was some excellent phase 3 clinical trials that has given us better data in terms of new effective treatments for NMO, which I'm going to come to shortly. But this just gives you a sense of the range. And you can see that a lot of the medications that were recommended were older medications that are often used for diseases like rheumatoid arthritis or myasthenia gravis. And so we didn't at that time have any NMO specific medications. So here's a real challenge I've had. This young woman who again, was one of my early NMO patients. She was 50 at the time of the onset of her disease. And she had a really severe onset. She would have these, I find that for some patients at the beginning, they can have multiple attacks within 1 month, leading quite rapidly to complete blindness or quadriplegia in her case. And she didn't respond to plasma exchange or steroids, and we tried and eventually gave her chemotherapy induction with an old French drug called mitoxantrone. And I should apologize at this time for talking about a lot of medications off-label. So my apologies for that. It's just it's a rare disease, and so often we are taking things off the shelf to try to treat it. But fortunately, she was actually my first chemotherapy induction patient, and she did fantastic. She went from quadriplegia to using a cane to get out of hospital, which was a nice improvement. And then I put her on to rituximab, so anti-CD20 therapy, was well for 4 years, and then again the disease becomes unstable and had to do combination therapy, and then was getting infections from combination therapy. Eventually, about a year or two ago, I switched over to combination with satralizumab and mycophenolate, and she's done very well on that. It was good stability with no further infections, and so she's been on that for about 2 years now and quite stable. But it is quite challenging to know which medication to start with, when to switch versus add combination. What I'd like to briefly present now is these 3 new medications that are tested specifically in NMO, mostly in antibody-positive NMO patients. And that gives us good evidence of 3 different mechanisms for treating NMO. So here's just a cartoon showing the targets, potential targets. So going after antibodies or cells that produce antibodies, or going after complement, which is part of the inflammatory pathway. And so we have currently clinical trials with 3 different drugs with 3 different mechanisms. So eculizumab is a complement inhibitor. Satralizumab does block interleukin-6 trafficking. And so it decreases or modulates B-cell function without causing B-cell depletion. And then we have the anti-CD19 Initialism, which is similar to an anti-CD20 medication by depleting B cells every 6 months by infusion. And so here is the Initialism data, as well as the Eculizumab data. These were all antibody positive patients looking at about 48 weeks outcome, so about 1 year. In the case of Initialism, that was just at 28 weeks. So it was a single infusion of the drug, and patients were on steroids as well. And so you can see that with both these drugs, you're seeing excellent prevention of relapses in the active treated cohort compared to the placebo. And in the case of Eculizumab, the placebo cohort, most of them are on standard of care therapy with azathioprine or mycophenolate. Then we had data with Satralizumab, the anti-IL-6 therapy. The nice thing with this research is we had 2 independent studies. One was a combination trial. So the placebo group here was on standard of care, azathioprine or mycophenolate, compared to Satralizumab with standard of care. And you can see a beautiful outcome at week 48 after a year of treatment. Very few patients on Satralizumab in combination had any breakthrough disease compared to the standard of care where 60% had a relapse by that point. Or sorry, 60% were relapse free, so 40% had a relapse. And then on the monotherapy, again, excellent control of the disease on monotherapy with Satralizumab, whereas patients on placebo, about half the patients had a relapse within a year. Fortunately, the design of the study allowed us to be very aggressive with treatment of relapses, and so we didn't see any patients accumulate disability in either of these studies, which is encouraging. So summing up, this is my current treatment algorithm in Vancouver. And so these 3 drugs I would consider my first-line choices. Satralizumab I would favor because it's more effective than azathioprine and mycophenolate Mofetil, and we have evidence to support it. If they have failure on azathioprine and mycophenolate, then escalate to either Satralizumab or anti-CD20 rituximab. I would also consider combination therapy with Satralizumab plus another agent. The safety is quite good with doesn't increase the risk of infections, but combination I find is quite common, and I can't get patients completely off prednisone, some of them anyways. And then 4th line, we do have coverage or availability of Eculizumab in Canada. Initialism was not put forward in Canada, so we're not using that one. But I think a similar drug would be the rituximab. Rarely am I using cyclosporin or cyclophosphamide or regular Plex. So it's mostly stopping at 3rd-line treatments for most of my patients. Seems to be successful. So in summary, I really appreciate your attention. I wanted to review some of the differences, uniqueness and novelty of NMO, and what really changed our world was having those antibody testing available that helped us redefine the disease and come up with very effective treatments for it. The antibody testing is very sensitive and quite specific, which is encouraging. Where we still have our challenges, of course, are the antibody negative patients. Should we treat them like NMO? Because our current data now really supports antibody positive patients. And also, how are we going to treat these spin-offs such as MOG antibody disease? One thing to be aware of with the challenging diagnosis is those disappearing lesions, and sometimes not all onset disease is severe disease. I've seen mild or short cord lesion myelitis, and so the index of suspicion can be helpful when in doubt. To the antibody testing, although I don't advocate doing antibody testing on everybody. That looks like classic MS. And I covered some of the different treatments. We now have good randomized control clinical trial data for Satralizumab, Eculizumab, and Initialism. But we still often are using other steroid-sparing agents as well, but it's not unusual to use combination treatment. So I want to thank you very much, and I'm very grateful to the wonderful team that supports my research.